Welcome back to Open Med School. I am Dr. Andrews. Today I am going to discuss Internal Medicine Competency 4.3 Common Causes, Pathophysiology and Manifestations of Fever in Various Regions of India. We will discuss bacterial, viral and parasitic cause of fever, that pathophysiology and clinical manifestation across different regions of India. I am not going to discuss about the fever due to immunological causes, malignancy, and the common respiratory, upper respiratory infections. First, we'll take the common bacterial causes. Among the bacterial causes, one of the important condition is typhoid fever. The classical fever pattern of typhoid is called step ladder. That is, a fever gradually goes up like this, and so it's uncommon to get rigors and chills in entry fever. The typhoid and paratyphoid fever together called entry fever. Typhoid fever is caused by Salmonella typhi, and the paratyphoid fever by the Salmonella paratyphi. The transmission is fecal-oral route. Clinical features, as mentioned, it produces step-ladder fever, can produce relative bradycardia. By relative bradycardia, we mean the expected rise in pulse rate. With each 1 degree centigrade rise, usually expect 10 increase in heart rate. That is not seen. And it produces hepatosplenomegaly. But when as it is a septicemia, sometimes this can present fevers and rigors. Or when it produces osteomyelitis, polycystitis, etc., also this can produce rigor, but it is uncommon in rigor, in typhoid fever. Next important fever is the scrub typhus. It is caused by Orientia twistigmashi. The mode of transmission is mite. At the clinical features, the classical important thing is the scar. At the bite site of the mite can produce fever, lymphadenopathy, and it may imitate leptospirosis and dengue fever. So anybody coming with a fever, we should think about the possibility of a scrub typhus, and sometimes leptospirosis and scrub typhus can coexist. Next important fever is leptospirosis caused by Leptospira icterohemorrhagia. That is, the classical condition is the Weil's disease. The Indrogan species, the mode of transmission is contact with the contaminated water. When it produces jaundice and renal failure, this is called the Weil's disease. It has got a significant hemorrhagic manifestation, this classical subconjunctival hemorrhage. In addition, there is thrombocytopenia and can produce cutaneous bleeding also. So these are all fevers without localizing signs. When you come across a patient with a fever, the first thing is you think about the common upper respiratory infections, that is running nose, sore throat, etc. These are due to the viral causes. Then think about single organs that produce fever. For example, in the brain, meningitis, encephalitis, there will be headache, vomiting, altered sensorium. Second is pneumonia, when the patient will have cough, breathlessness, and hemoptysis sometimes. Then the liver, the producer right upper abdominal pain, discomfort, loss of appetite, nausea, vomiting. Then the urinary infection, especially the pyelonephritis that presents with fevers, rigors and chills. So these are the common single organ diseases. When there is no single organ illnesses, just comes with the fever, you think about the classical disease that we have mentioned. One is leptospirosis, second is a scrub typhus, That is the dengue fever. All these are presenting with undifferentiated fevers without localizing signs, but fever and myalgia is the predominant feature. And when none of these are present, think about typhoid fever. And any patient with a history of travel outside, think about malarial fever. This is how you approach a patient. Now, among the viral fever, as mentioned, dengue is one of the important cause of acute febrile illness. It is caused by dengue virus, the flavivirus. Aedes aegypti is the mosquito that is transmitting the disease. This produces classically a biphasic or saddle-shaped fever. That is, a fever comes or lasts for a few days, it subsides, and then the fever again increases. Typical feature is the retroorbital pain and rashes and significant thrombocytopenia. Leptospirus also produces thrombocytopenia, but it is much higher in dengue. The count around 20,000, 10,000, etc. is more in favor of dengue than leptospirosis. This is what is mentioned by the saddle or a biphasic fever. The fever lasts for a few days, then the fever subsides, and again the fever recurs. This is typically seen in dengue fever. And in dengue, the initial period, the first 4 days, there is viremia, and the testing is the you go for the NS1 antigen, and after around 4 days, the IgM antibody rises along with the IgG also. So, depending upon the time of illness, you have to select the test. NS1 will be positive in the initial 3-4 days, and after 4 days, the IgM antibody becomes positive. Chikungunya, the causative agent is the Togaviridae chikungunya virus. Mode of transmission again it is mosquito. Severe polyarthritis, fever. There can be maculopapular rash also. So this joint pain can last for several weeks and even months, and may just the polyarthritis, symmetrical upper limb, hands and feet, something similar to rheumatoid arthritis we can get. Then certain parts of Karnataka, the KFD, Kaisner forest disease. Causative agent is KFD virus, flavivirus. This by tick bite. Clinical feature high fever, hemorrhagic manifestation, and neurological symptoms. There are certain emerging viral illnesses. An example is a typical Nipah virus, then the avian flu, the Zika virus, Ebola virus. Many of them produces fever, respiratory distress, encephalitis, and bleeding manifestations. So many emerging viral illnesses are there. We had a local epidemic of Nipah virus in Kerala. This is transmitted from the bats, the fruit bats. Again, it presents respiratory distress and neurological manifestations. Think about Nipah virus. Now we go to the parasitic cause of fever. The malaria is the number one. Plasmodium falciparum and vivax are the common ones. Mode of transmission is Anopheles mosquito bite. Fever with chills and rigors and splenomegaly is common. They can develop anemia because of the hemolysis that is occurring. Different fever patterns are there. Initially, the fever can be controlled in daily fever can be there. Then the fever goes into the Plasmodium vivax, it goes to every third day. So it's called a tertian fever. You can get coercion fever in Plasmodium malaria infection. Every fourth day the fever occurs. So the classical fever pattern, there is a chilly sensation, that is a cold stage, followed by a hot stage, rigors and chills followed by the hot stage, which may last for few hours, and the fever subsides with the crisis. Profuse sweating. And usually these cycles will repeat as the patterns have already been mentioned. In falciparum malaria, the fever pattern may not be a typical one, it may just imitate any viral illness, especially in the initial days until the patient develops some complications like cerebral malaria. Next is Kalasar in many parts of Bihar and northern states. Visceral leishmaniasis, Kalasar, because that the pigmentation is called Kalasar, dark color. Causative agent is Leishmania donovani. The sandfly, phlebotomous sandfly is the transmission. Clinical features: prolonged fever, hepatosplenomegaly produce pancytopenia. So see the massy splenomegaly. As mentioned, transferred by bite of sandfly. So diagnostic algorithm: any patient take a travel history, exposure to animals, insects, and occupation. Duration of pattern of fever, ask about the rash, jaundice, respiratory symptoms, joint pain, and neurological signs. As mentioned, you think about the highest order can this be malarial fever. Ask about the travel history. Then think about the single organs, brain, lungs, liver, kidneys, and any soft skin and soft tissue infections. If none of them are fever and myalgia syndromes, think about leptospirosis, dengue fever, and chikungunya. If none of these are there, think about typhoid and scrub typhus. This is a simple way of looking at the febrile illnesses. So, initial laboratory test will be you go for a CBC with the differential. The dengue and leptospirosis may imitate. Total count will be elevated in leptospirosis because it is a bacterial disease or a spirochetal disease. Count will be low in dengue. Significant thrombocytopenia is a point favoring dengue fever. But thrombocytopenia can occur in many other diseases like dengue, leptospirosis, malaria. Peripheral smear examination for malaria or rapid test can be done. Vidal and clot culture if typhoid is suspected. Dengue NS1 antigen or IgM serology depending upon the time. Think about the wheel Felix test for scrub typhus, ELISA test for chikungunya. So differential diagnosis, you think about fever with rash. I already mentioned dengue, chikungunya, KFD, measles, and many recurrent diseases. Drug fever also. Fever with hemorrhagic signs: dengue, KFD, leptospirosis, Ebola. Fever with respiratory distress, COVID, viral respiratory infection, influenza, Nipah. Fever with mental status changes can get in scrub typhus, meningitis, malaria, and encephalitis. I not covered the drug-induced fever, neuroleptic malignant syndrome, and the heat stroke, etc. There are innumerable causes for other causes for fever also. Somebody coming from a hot climate, think about the heat stroke. Somebody is on antipsychotics, think about the neuroleptic malignant syndrome. You may go for blood culture and PCR for viral pathogens, CSF analysis if meningitis is suspected, take an X-ray chest, ultrasound abdomen for visceral involvement. Empirical management should be done based on likely diagnosis. If you are suspecting scrub typhus, give doxycycline. Malaria, depending upon the local protocol, you should go for the management. Isolation and supportive measures for viral hemorrhagic fevers. So, depending upon the region, North India, dengue, typhoid; North East India, scrub typhus, malaria; South India, leptospirosis, KFT, and chikungunya. And northern India again, the malaria, should also be considered. In coastal regions, leptospirosis or agricultural field workers.